Welcome to another episode from the Veterinary Medicine Digest. Today, we are diving deep into a topic that nearly every small animal practitioner encounters, often daily: ear disease. But this is not just about the common, itchy outer ear infections we are all familiar with. We are going to explore the hidden, complex, and often underdiagnosed world of otitis media, or inflammation of the middle ear, in our canine and feline patients. This condition is far more than a simple earache. It is a common inflammatory disease that frequently goes unrecognized in veterinary practices. When left unchecked, it can lead to chronic pain, hearing loss, and even life-threatening neurological complications. We will unravel the distinct ways this disease presents in dogs versus cats, navigate the intricate pathways of diagnosis from basic otoscopy to advanced imaging, and discuss the multifaceted treatment strategies required to bring relief to our patients. We will even touch on how these issues can manifest in other small companions, like rabbits. So, settle in as we explore the challenging but crucial world of otitis in small animals. Otitis media is an inflammatory disease process that takes place within the middle ear cavity. While it might sound like a specific and isolated problem, it is often intertwined with other conditions, particularly otitis externa, which is inflammation of the outer ear canal. In fact, the connection is so strong that in dogs, secondary otitis media is thought to occur in about 16% of acute outer ear infection cases and in a staggering 50 to 80% of chronic outer ear infection cases. This statistic alone should give us pause. The very fact that otitis media is present in more than half of canine patients suffering from long-term outer ear infections should prompt a reformulation of our thought process when we are faced with these challenging cases. A common history of a patient being treated repeatedly for ear infections should immediately raise our suspicion and alert us to think about otitis media as a distinct possibility. Beyond the ears themselves, otitis media should also be on our differential list whenever we are presented with a patient showing any neurological disease affecting the head, including vestibular disease, Horner syndrome, or facial nerve damage. Similarly, otitis interna, an inflammation of the inner ear, can cause the classic signs of peripheral vestibular disease, such as a head tilt, nystagmus, and ataxia, because this is where the sensory organs for balance are located. Now, let's turn our attention to our canine patients, who present a unique set of challenges largely due to their anatomy. The diagnosis of otitis media in dogs can be quite difficult to make because of the long, bent, funnel-shaped conformation of the dog's ear canal, which makes it incredibly hard to see the tympanic membrane, or eardrum. This L-shaped configuration also means that exudates and destructive proteolytic enzymes produced during an outer ear infection tend to accumulate right up against the thinnest portion of the eardrum. The resulting inflammation and enzymatic destruction lead to necrosis of the eardrum's epithelium and its supporting collagen, which causes the eardrum to thin and weaken over time. This can lead to ulceration along the ear canal that extends to the eardrum itself. The ulcerated tissue leaks serum, which can cause maceration and further damage to the epithelium. When you combine this with the liberation of bacterial proteases, collagenases, and other destructive enzymes from phagocytic cells, the stage is set for erosion or outright rupture of the eardrum. When this rupture happens, it creates a direct pathway for exudates and infectious organisms from the external ear canal to drain into the middle ear, where they get trapped in the ventral portion of the bulla, the bony cavity that encloses the middle ear structures. Once medications, chemicals from ear flushing products, or debris from the external canal enter the middle ear through this eroded eardrum, a tissue reaction begins in the respiratory epithelial lining of the middle ear. This entire process is what we call secondary otitis media. This is the predominant cause of otitis media in dogs, acting as an extension of an otitis externa. It's a complex and often multifactorial process. It is often theorized that otitis media is simply an extension of an outer ear infection that was not treated, was improperly treated, or was resistant to treatment, ultimately resulting in significant damage that creates porosity in the eardrum over time. Interestingly, a significant number of canine patients with otitis media, up to 70% in one report, have an intact eardrum when they are examined. This can give the clinician the false impression that there is nothing wrong in the middle ear, while in reality, the eardrum may have previously ruptured and then healed, trapping bacteria and yeast within the tympanic bulla. These patients may have a history of repeated episodes of ear trouble because of this alternating cycle of eardrum rupture and subsequent healing. To add another layer of complexity, there's a condition described in dogs called a false middle ear. This can happen when obstructions along the horizontal ear canal, such as from hypertrophic glands, tumors, inflammation, or cerumen plugs, increase pressure on the eardrum, causing it to stretch and bulge into the middle ear cavity. If there is also poor air movement through the eustachian tube, a negative pressure inside the bulla can pull the eardrum even further inward, creating a balloon-like distension into the bulla. This invaginated eardrum can collect large amounts of debris like keratin and wax, forming a cavity that needs to be flushed out thoroughly. These cases are often misdiagnosed as having otitis media, but a follow-up check 2 weeks later might reveal the previously unseen eardrum has returned to its normal location. Brachycephalic breeds, such as the French Bulldog, present their own unique challenges. These breeds are predisposed to a condition known as primary secretory otitis media, or middle ear effusion. This condition, which shares similarities with glue ear in children, is characterized by a highly viscous mucus plug filling the tympanic bulla. The cause is thought to be multifactorial, stemming from their unique anatomy, including a thickened soft palate, smaller bulla volume, and auditory tube dysfunction that prevents proper drainage. What's particularly tricky is that this middle ear effusion is often asymptomatic and discovered as an incidental finding during computed tomography or magnetic resonance imaging scans for other issues. A recent study found that 58% of French bulldogs with no clinical signs of ear disease had material within the tympanic bulla on magnetic resonance imaging scans, and of those, 59% had it in both ears. This high prevalence is important to remember when we image a French bulldog for chronic otitis externa, as they may have a concurrent and possibly unrelated middle ear effusion. The clinical signs of otitis media in dogs can be varied. More commonly, a dog with otitis media has a history of recurrent or chronic bacterial external ear infections. When the eardrum is open, these dogs and cats often have a copious, malodorous liquid discharge present when the ear canal is examined. A key sign to look for is the presence of copious mucoid exudate along the floor of the horizontal canal. Mucus is not produced anywhere in the external ear. It oozes from the tympanic bulla into the horizontal canal through any rent in the eardrum. Therefore, the presence of mucus means there's a hole in the eardrum, even if you cannot see it. Some patients produce so much exudate that it overflows onto the face, or in a dog with floppy ears, you might see dried exudate on the ear flap. Head shaking is common, and it is wise to check for otitis media in any case of an oral hematoma. Pain on palpation of the base of the ear, or when manipulating the ear flap, should also raise suspicion. Some dogs may even become aggressive when owners try to administer medication due to the intense pain. Reluctance to open the mouth or chew hard food can also be a sign, resulting from inflammation and swelling within the bulla, which is located right next to the temporomandibular joint. When otitis media affects the nerves that run near or through the tympanic bulla, a range of neurological signs can appear. This can be as subtle as dry eye on the same side, resulting from damage to a branch of the facial nerve. If the sympathetic nerves are affected, the patient might show mild signs of Horner syndrome, which include a sunken eye, droopy eyelid, and constricted pupil. Because the facial nerve courses in and around the ear canal, it is easily affected by swelling and inflammation, which can lead to facial neuropathy. This should be suspected if there is drooping of the facial muscles, drooling, or an inability to close the eyelid. And of course, if the infection and inflammation extend to the inner ear, we may see signs of peripheral vestibular disease, such as a head tilt, circling, and nystagmus, which is an involuntary eye movement. Moving on to our feline patients, the picture of otitis media looks quite different. For one, diagnosing otitis media in cats may be easier with an otoscope because of their relatively short ear canals. While dogs most often develop secondary otitis media from external ear infections, primary otitis media is more common in cats and often results as a sequela to respiratory disease. Therefore, a history of sneezing or ocular or nasal discharge can be a clue. This type of otitis media occurs as a result of infection ascending through the eustachian tube, also known as the auditory tube, to the middle ear. The bacterial isolates from the bulli of cats with middle ear disease are often consistent with respiratory pathogens. Organisms that are much more difficult to culture, such as Mycoplasma and Bordetella, have also been cultured from the middle ear of cats with this condition. Stress and overcrowding, such as in hoarding environments, can predispose cats to chronic upper respiratory infections, which can involve in nasal passages, nasopharynx, auditory tubes, and middle ear, leading to a high risk of otitis media. Another major player in feline otitis media is the oral inflammatory polyp, often abbreviated as AIP. These are non-cancerous, pedunculated growths that frequently originate from the epithelial lining of the middle ear or the auditory tube. They're the most common benign tumors of the feline ear. As they grow, they can extend through the eardrum into the external ear canal or through the auditory tube toward the nasopharynx. When found in the external ear canal, the presence of a polyp is usually associated with a secondary bacterial otitis media, and these cats can produce copious amounts of mucus and pus. Otitis media and interna, or OMI, in cats is most commonly associated with these polyps or with inflammation from an upper respiratory infection that has extended through the auditory tube. Oral inflammatory polyps are frequently seen in young cats, with an average age of 1 to 4 years old, and are most common in domestic shorthair cats. However, some studies suggest that Maine Coons may be overrepresented, and it has been proposed that the condition could be inherited or congenital in this breed, possibly due to a unique anatomical conformation of the auditory tube. The clinical signs associated with these polyps often mimic those of otitis externa, media, or interna. The most common signs are related to outer ear inflammation, including head shaking, ear scratching, and discharge. However, neurological signs consistent with middle ear disease, like Horner syndrome and facial nerve paralysis, are also routinely identified. If the inner ear is involved, signs can include ataxia, hearing loss, head tilt, and nystagmus. In fact, middle ear polyps are associated with almost 9 times the odds of presenting with Horner syndrome compared to other causes of vestibular syndrome. This strong association is due to the anatomical relationship between the structures of the middle ear and the sympathetic nerves that pass through the tympanic bulla. Diagnosis of these polyps is primarily based on visualizing them through otoscopy, whether with a traditional handheld otoscope or a video otoscope. They typically appear as smooth, pinkish to white-colored, rounded masses in the external ear canal or middle ear cavity. There may be so much purulent or ceruminous exudate in the canal that an in-clinic cleaning is required just to identify the polypoid mass as the underlying cause of the otitis. Once a polyp is diagnosed, treatment often involves its removal. One of the simplest methods is traction and avulsion. Under general anesthesia, forceps are used to grasp the mass, and a swift twisting motion is used to avulse it. The goal is to remove the entire polyp, including its stalk. A more precise variation of this technique uses a polypectomy snare passed through the working channel of a video otoscope, which allows a larger amount of tissue to be secured and removed in a single attempt, thus reducing anesthetic time. Following removal, it is recommended to address any residual inflammatory tissue and reduce the chance of recurrence with a tapering course of oral prednisolone for about 8 weeks. Historically, the recurrence rate for polyps has been higher in cats treated with traction and avulsion alone compared to those treated with a more invasive surgical procedure called bulla osteotomy. A 4-week tapering course of prednisolone administered after traction and avulsion was associated with a statistically significant reduction in the rate of recurrence. Alternatively, bulla osteotomy, which involves a ventral surgical approach to the bulla, allows for more complete removal of inflammatory tissue from both chambers of the cat's middle ear. This may be the preferred option in severe cases, when a polyp is confined to the bulla or when a polyp recurs after being treated with traction and avulsion. However, bulla osteotomy is not without its risks. Postoperative complications can include Horner syndrome, vestibular disease, facial nerve paralysis, and airway obstruction. Horner syndrome, in particular, occurs much more commonly with bulla osteotomy, seen in up to 80% of cases, compared to 40% with traction and avulsion, though it usually resolves within a few weeks to months. Diagnosing otitis media, whether in a dog or a cat, with or without a polyp, requires a thorough investigation that goes beyond a simple glance into the ear canal. Otoscopy is the principal diagnostic tool, but a careful examination of the eardrum in a patient with otitis media requires general anesthesia. This is especially true if there is significant stenosis or narrowing of the external ear canal from inflammation or permanent pathological changes, which may make it impossible to see the eardrum. In these cases, a course of potent topical or systemic corticosteroids may be needed to reduce the swelling and allow for an examination on a subsequent visit. The introduction of video otoscopes has revolutionized our ability to examine the ear canal and eardrum. These instruments provide excellent lighting and a detailed, magnified view on a monitor. Once a veterinarian becomes comfortable with what a normal eardrum looks like, its location, color, clarity, and tension, using it to diagnose otitis media becomes much easier. If the eardrum is translucent, the bright light from the video otoscope can even transilluminate the middle ear, allowing visualization of its contents. In obvious cases of canine otitis media, there might be no eardrum present at all. The ear canal is filled with a liquid secretion, and sometimes only a small ring of granulation tissue may be seen where the eardrum used to be attached. When the middle ear is not actively producing pus, it might just look like a deep dark hole. In other cases, the eardrum is intact but looks abnormal. It might become opaque and gray instead of pearly and translucent, or might bulge into the external ear due to fluid pressure behind it. Purulent material in the middle ear might be visible as yellow fluid behind the eardrum. This is why the presence of an intact eardrum does not rule out otitis media, particularly in dogs with chronic outer ear infections. But what if the ear canal is so narrow that the eardrum cannot be visualized at all? Several techniques can help determine its integrity. A small diameter catheter can be inserted into the ear canal until it stops. A spongy feel suggests the eardrum is intact, while a hard stop suggests it has ruptured and the catheter is hitting the medial wall of the bulla. An easier, indirect method is to infuse a warmed, diluted solution like povidone iodine into the ear canal of the anesthetized animal. If the fluid comes out of the nose or the patient snorts it out, the eardrum is ruptured, as the fluid has flowed from the external ear, through the middle ear, and out the auditory tube into the nasopharynx. Positive contrast canalography is another method where a dilute contrast agent is instilled into the ear canal, followed by an X-ray. If the eardrum is intact, there will be a distinct contrast air interface at the eardrum. If not, the contrast material will enter the bulla. Sometimes, to get a definitive diagnosis, it is necessary to perform a meningotomy, which is a controlled incision into the eardrum. This allows for the collection of cytology or culture specimen from the material trapped behind the eardrum and also immediately relieves the intense pain associated with pressure changes. The procedure is done under anesthesia after thoroughly cleaning the external ear canal. A sterile, sharp-pointed instrument, like a cut catheter or a long spinal needle, is used to puncture the eardrum in a specific location to avoid important structures. Carbon dioxide lasers are also increasingly being used, which can melt a clean, circular hole in the eardrum without actually touching it, reducing the chance of contamination. Once the incision is made, fluid might freely flow out and should be suctioned. A catheter can then be advanced into the bulla to retrieve material for cytology, bacterial culture, and antibiotic sensitivity testing. It is important to obtain samples for both cytology and bacterial culture because infections are often polymicrobial, involving both bacteria and yeasts. Cytology might reveal Malassezia yeasts, which would not be reported if only a bacterial culture was submitted, while at the same time, bacteria can be hidden from cytology stains by mucus, making a culture essential. Beyond looking directly into the ear, advanced imaging plays a crucial role. Radiographic assessment of the bulla can be helpful in determining the extent of bony involvement and whether there is increased tissue or fluid filling them. When the bulla is chronically affected, there might be new bone production, proliferation, or bone lysis. However, the absence of radiographic changes does not rule out otitis media, especially in more acute cases, and radiographs are less sensitive compared to computed tomography and magnetic resonance imaging. Computed tomography, when available, is superior for differentiating bony lesions from soft tissue reactions and is particularly helpful for evaluating the ear canal and bulla when stenosis is present. In cats with oral inflammatory polyps, computed tomography can reveal specific features like a stalk-like structure, strong rim enhancement of the mass, and expansion of the affected bulla, which can help differentiate a polyp from malignant mass. Magnetic resonance imaging is also being used to assess the middle and inner ear, and it is particularly sensitive for detecting changes in soft tissues. The fluid within the inner ear structures can provide natural contrast, which is useful for evaluating the inner ear. Most importantly, magnetic resonance imaging is the gold standard for detecting the extension of infection into the meninges or the brain parenchyma itself. A specific magnetic resonance imaging sequence called fluid attenuated inversion recovery, or FLAIR, has shown great utility. The fluid in a normal inner ear, the perilymph, is very similar in composition to cerebrospinal fluid and should suppress, or appear dark, on these sequences. In cases of otitis media and interna, inflammation leads to an influx of cells and protein into the perilymph, causing it to lose this suppression and appear brighter. Studies have shown that cats and dogs with otitis media and interna have significantly lower fluid-attenuated inversion recovery suppression in their inner ears compared to healthy animals, making this a useful, non-invasive way to help diagnose inflammatory inner ear disease. On post-contrast images, enhancement of the meninges, the membrane surrounding the brain, may be visible. However, One study found no association between this meningeal enhancement and abnormalities in the cerebrospinal fluid, and noted that meningeal enhancement was seen in nearly half the cases of otitis media and interna, but only about a quarter of those also had abnormal cerebrospinal fluid. This suggests that while magnetic resonance imaging is invaluable, cerebrospinal fluid analysis may still be needed to detect concurrent meningitis. This brings us to the serious, and sometimes life-threatening, complications that can arise when an ear infection is not contained. When otitis media affects the nerves coursing around the ear or through the bulla, a host of neurological problems can emerge. As we touched on earlier, this can include vestibular syndrome, which presents with a head tilt, ataxia, and nystagmus, Horner syndrome, and facial nerve paralysis. Vestibular syndrome is a frequently encountered problem in feline neurology, and otitis media and interna is one of the most common causes. Studies have shown that otitis media and interna accounts for 28 to 63% of cats presenting with peripheral vestibular signs. In dogs, idiopathic vestibular disease is the most common cause of peripheral vestibular dysfunction, but otitis media and interna is a close second, accounting for about 26% of cases in one large study. When the infection extends beyond the middle and inner ear, it can lead to intracranial abscessation or empyema. An intracranial abscess is a collection of purulent material within the brain tissue itself, while an intracranial empyema is suppuration within a pre-existing anatomical space, like the subdural space. These conditions arise as a consequence of bacterial infection within the cranial cavity, often from local extension from the ears or sinuses, or secondary to trauma, like cat bite wounds. Male cats seem to be overrepresented, possibly due to an increased likelihood of fighting. These cases present with a wide range of progressive, multifocal neurological deficits that reflect the lesion's location and the secondary mass effect. Advanced imaging with computed tomography or magnetic resonance imaging is crucial for diagnosis. Treatment is an emergency and consists of either aggressive medical management with broad-spectrum antibiotics or a combined medical and surgical approach involving a craniectomy to drain the pustular material. Interestingly, a retrospective study of 23 cats found no statistically significant difference in short or long-term survival between the medically managed and surgically managed groups, suggesting that in some cases, these severe infections can be successfully treated with medical management alone. Another serious complication is otogenic meningitis or meningoencephalitis, which is inflammation of the meninges or the brain parenchyma itself due to an extension of the ear infection. This condition is particularly prevalent in brachycephalic breeds. One study found that 96% of dogs with otogenic meningoencephalitis were brachycephalic. The classic signs of bacterial meningitis in people, pyrexia, neck stiffness, and altered mental status, are not always present in dogs, making diagnosis challenging. A significant finding from recent studies is that neurological examination alone is often not accurate in identifying this intracranial extension. A study of 30 dogs found that intracranial extension was not recognized on neurological exam in 67% of cases. Many of these dogs only showed signs of peripheral vestibular disease. This underscores the importance of considering intracranial extension even in patients that appear to have a purely peripheral problem and recommending advanced imaging and cerebrospinal fluid analysis, especially for chronic or recurrent cases in brachycephalic breeds. Despite the severity of these complications, the prognosis can be good with appropriate treatment. The majority of dogs with otogenic meningitis survive to hospital discharge and make a full recovery, although some may have mild residual deficits like a persistent head tilt. Now, let's transition to treatment. Planning the treatment of otitis media requires a stepwise, organized protocol for maximum effect. The first step is to gain access to the middle ear, as we discussed with otoscopy and meningotomy. The second is to collect samples for cytology and bacterial culture. Many infections are polymicrobial, involving mixed infections of bacteria and yeasts. It is also critical to remember that the antibiotic sensitivity of organisms isolated from the horizontal ear canal can be different from that of organisms isolated from the middle ear in almost 80% of cases. Perhaps the single most important technique for treating otitis media is flushing the bulla. Topical medications simply cannot penetrate through the thick exudate and mucus that fill the middle ear, so this material must be removed. Furthermore, many destructive enzymes remain trapped in these secretions, prolonging the disease. Using fluid under high pressure to irrigate the bulla loosens the mucus and pus, which can then be suctioned out. This process is best observed with a video otoscope to ensure the cleaning is thorough. Once the bulla is clean, the next step is bulla infusion. This allows aqueous formulations of non-ototoxic topical antibiotics, steroids, or antifungals to be placed directly onto the inflamed mucoperiosteum, the lining of the middle ear. This is an incredibly effective method because the tympanic bulla is a deep, blind pouch with poor drainage. The infused medication can remain in contact with the inflamed tissues for several days, achieving concentrations many times higher than what could be achieved with systemic therapy alone. With each weekly treatment of flushing and infusion, the inflamed lining should retract, increasing the volume the bulla can hold. This brings us to the critical topic of ototoxicity. When the eardrum is perforated or absent, topical medications and chemicals and ear cleaners can gain access to the inner ear through the round and oval windows, resulting in neurological ototoxicity. This results from damage to the delicate hair cells in the cochlea or the vestibular apparatus, leading to hearing deficits, vestibular disease, or both. Many common ear cleaning solutions and topical antibiotics contain potentially ototoxic substances. Of these, chlorhexidine is probably the most toxic, especially in cats, and its use in ears is strongly discouraged. The aminoglycosides like gentamicin and neomycin, as well as polymyxins and most alcohols, are also known to be toxic to the inner ear structures. An assessment of the risks versus the therapeutic benefits must be made when considering these drugs for otitis media. Fortunately, there's a list of products that can be safely infused into the tympanic bulla. For antibiotics, these include the fluoroquinolones like enrofloxacin and ciprofloxacin, aqueous penicillin, and some cephalosporins. For antifungals, clotrimazole and miconazole are safe options. The ceruminolytic squalene and the flushing agent tricidTA are also safe for use in the middle ear. Corticosteroids play a vital role in slowing the intense inflammation and exudation found in middle ear disease. They can reverse some of the extensive granulation tissue that forms, which enhances the ability of topical antibiotics to penetrate infected tissue. They also reduce the amount of mucus produced and decrease its viscosity, aiding in its removal. Aqueous topical corticosteroids like dexamethasone sodium phosphate can be infused directly into the clean bulla. If space is needed for antibiotics, systemic corticosteroids can be used for a few weeks, though owners need to be warned about the potential side effects. For some cases of chronic otitis media, medical therapy is not enough and surgery becomes necessary. For cats with inflammatory polyps, this may involve a ventral bulla osteotomy, often abbreviated as VBO. For dogs and cats with end-stage ear disease, a total ear canal ablation and bulla osteotomy, often abbreviated as TEC-LBO, may be required. A recent retrospective study of 58 previously hoarded cats undergoing ventral bulla osteotomy for chronic otitis media and interna provides a sobering look at this procedure. While surgical management was successful in most cases, resolving issues like purulent discharge and nasopharyngeal signs in a significant proportion of cats, it was not benign. Complications were frequent and often serious. Postoperative Horner's syndrome occurred in over 70% of cats. Life-threatening perioperative airway obstruction occurred in several cases, especially when bilateral surgery was performed simultaneously, suggesting that staging these procedures is safer. Other serious complications included the new onset of otitis interna, prolonged anorexia, and a condition suspected to be xerostomia or dry mouth, which was associated with brown discoloration of the tongue. This study highlights that while surgery can be beneficial, the risks are substantial, and it may not resolve all clinical problems, particularly pre-existing neurological deficits like a head tilt. Finally, while our focus has been on dogs and cats, it is worth briefly mentioning that our smaller furry companions, rabbits, also suffer from similar issues. Head tilt is the most prevalent manifestation of neurological disease in rabbits, and like in cats and dogs, it suggests vestibular disease. The two most common causes of head tilt in pet rabbits are otitis media and interna, and a parasitic disease called encephalozoonosis. The clinical signs can overlap significantly, making it challenging to differentiate between the two. Therefore, for any rabbit presenting with a head tilt, a baseline investigation should ideally include both paired serology for the parasite and a computed tomography scan of the head to evaluate the ears. In conclusion, otitis is a profoundly complex and varied disease that demands our full attention and a meticulous, systematic approach. It is far more than a simple, localized infection. In dogs, it is often a chronic sequela to external ear disease, driven by their unique anatomy. In cats, It frequently begins as an extension of respiratory illness or as a result of inflammatory polyps. The clinical signs can be subtle or dramatic, ranging from head shaking to severe, debilitating neurological dysfunction. Our diagnostic journey must be thorough, utilizing everything from careful otoscopy and meningotomy to the powerful insights of advanced imaging like computed tomography and magnetic resonance imaging. We must always be vigilant for the possibility of grave complications like intracranial abscesses and meningitis, especially in high-risk breeds, and recognize that a normal neurological exam does not rule out central nervous system involvement. Treatment is equally multifaceted, requiring not just antimicrobials, but aggressive cleaning, targeted topical therapy, and anti-inflammatory support, all while navigating the ever-present risk of ototoxicity. For some, surgery offers a cure, but it comes with its own significant set of risks that must be carefully weighed. Ultimately, successfully managing otitis in our small animal patients requires us to look deeper, think broader, and treat smarter, ensuring these common infections do not become chronic or life-altering conditions. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.